So it gives me great pleasure to introduce our next speaker, who's Amy Rosenthal, who's Executive Director of Healthcare for All. Healthcare for All is the premier healthcare consumer advocacy group in Massachusetts, working to promote health justice by reducing disparities and ensuring coverage and care for everyone. Amy has been working on these issues for many, many years. And she has held leadership positions in a wide range of healthcare organizations, hospitals, state government, consumer advocacy organizations, foundations, political campaigns. Before she became Executive Director of Healthcare for All, she was in charge of external affairs and campaigns at Community Catalyst, which is a nationwide consumer health advocacy group that's based in Boston but works across the country. Among the things she did there, she worked with the White House and HHS on implementing the ACA. And she also helped lead an effort called Protect Our Care. That was a coalition of national efforts who were working to defend healthcare and health reform. Most important for me to tell you about Amy is that she's an alum of the Harvard School of Public Health. So, Amy, welcome, and Amy's going to give us a patient's perspective on these topics. And I always have to observe, and this is always true at every conference, almost I'm ever at, the patient always comes last. So Amy, but we're very delighted to have you join us.
Thank you. Hello. I'm just going to set a timer here so that I don't keep us longer than we want to. Thank you, Nancy, and thank you, everyone, for having me today. I am going to talk about things from the consumer's standpoint, the patient's point of view. I want to do three things. I want to tell you a little bit about Healthcare for All. I then want to talk to you a little bit about process, and then I want to get into some substance and policy related to Massachusetts. So, as Nancy said, Healthcare for All advocates for health justice in Massachusetts by working to promote health equity and ensure coverage and access for all. What really grounds us in our work is our helpline. We have right now 4 helpline counselors that take 20,000 phone calls every year. We do this in 3 different languages. 50% of our calls come in either Spanish or Portuguese. We help anyone who calls us, but we find that many of the people that are calling are low income, people where English is not their first language, or people who frankly just have not had health insurance before and really need help navigating the system. So what's so grounding for us is that everything we hear on the helpline drives our policy agenda. So we hear about a problem on the helpline, and not only does it channel the work that we're doing, but it also helps us inform the state government, elected officials, and folks who have positions of power here in Massachusetts. And this has been done over the past 35 years, whether we have a Democrat or a Republican governor, and whether the legislature is always controlled by Democrats here. But we do work and have an open door to many people. Healthcare for All works in a variety of ways. Coalitions are very important to us. We work with dozens and dozens of organizations. We lead coalitions or co-lead coalitions on everything from ACA defense to oral health, children's health, patient confidentiality, immigrant health, and social determinants of health. And that's just what we're doing right now. Healthcare for All has also been involved in with every step of the way, the various phases of health reform that have happened here in Massachusetts, and played that critical role of making sure that the consumer voice was there, whether it was the very first universal health care law, which actually never took effect, to the Medicaid expansion and the kids coverage, which was the precursor to the Children's Health Insurance Program, to Chapter 58, which was the precursor to the ACA, and then to our price transparency and reform bill. So, as a consumer advocate, people always want to know what we think about how we're going to get to universal coverage. And obviously, there's been a lot of conversation about this today. I would argue, and this comes from both my experience now at Healthcare for All for the past year, but also my 12 years at Community Catalyst working on the national level, that states are truly the laboratories for federal government and federal policy making. It is very challenging to move policy making on the federal level. Not that it's easy to do it here in any state or in Massachusetts or in any state, but there is the ability to try to move an agenda and move health policy along through the process, particularly in a place like Massachusetts that is very progressive and really values this, what we refer to as a culture of coverage. There we go. And I think obviously Massachusetts is the perfect example of how we do this well. So this is a picture of the signing of Chapter 58. Obviously we've already heard a lot about it today. It wasn't, though, just the substance of the bill, Chapter 58, which led to the groundwork for the Affordable Care Act. It was also what we did in order to pass it and what we did around implementation that was of value to the folks on the national level. So I remember in my old job, I would fly down to Washington every Tuesday to meet with various people during the process of passage, implementation, and defense of the ACA. And people always wanted to ask questions about what was the nature of the group of people that came together that helped drive forward that legislation? What were the strategies that you used in order to do that? And while Massachusetts' environment is very different than what we see nationally, there were a lot of lessons that could be learned from that. Similarly, I would argue that once the law passed, there were also a lot of ways in which people were looking to the states to figure out what it was that they could be doing and how they could be advancing their agenda. Healthcare.gov, which is the online marketplace, they have a call center, and when they were getting ready to get up and running, they flew their entire team to Boston to sit with Community Catalyst and Healthcare for All to learn from our helpline and understand how consumer assistance can be done well. And so that brings us to the place here in Massachusetts. Again, we've seen these numbers earlier that we have made a lot of progress towards universal coverage. So close to 97% of our residents have health insurance, close to 98% of our children are covered. This is from the most recent CHIA report in December of 2017. So I think the question is, how did Massachusetts achieve this, and thinking also about the process and the advocacy strategies in which it happened. And I think the discussion that's happened today really speaks to the point that I was hoping to be able to make, and I feel like the entire day has teed me up for this. So I would argue that when you're thinking about advocacy and policy, it takes an entire continuum of strategies and ideas in order to move health policy forward. So in this diagram, we see our political center. We're kind of only looking on the left for the purposes of today's conversation. And you could label either end of this arrow a variety of different things. I call it pushing the envelope and pragmatic. You could call it very progressive and moderate. You could call it, liberal. You could use a whole bunch of different terms. And I would say that the debates that we have about Medicare for all versus incremental change, all of it fits somewhere on this continuum. And it's not any one strategy that moves us towards the goal of enhancing coverage for everybody. It's the combination of people pushing far out on the left, people working closer in the middle, and everything in between that is ultimately what's allowing us to advance our agenda. And this is true in advocacy and in policy. So if you look at the top left picture, those are folks who were working with organizations where it was a true kind of civil disobedience protest in the U.S. Capitol. They staked out various offices. Everyone was going in with the full intention of being arrested. They wanted lots of press coverage. They got lots of press coverage. I couldn't find the good picture of the people like in the wheelchairs literally being dragged out of the office. But this was a purposeful strategy that a lot of people used in order to protect the Affordable Care Act. The picture on the bottom right is a bunch of my students who are MD and PhD students at the Harvard School of Public Health who 2 years ago when Trump was first elected, they all put on their white coats, they flew down to Washington, they met with, in this picture I think it's Schumer and Warren, but they also met with plenty of Republicans. They took a much more moderated approach to having a conversation about why it was important that their patients have health insurance. I would argue both advocacy strategies are what helped us protect the Affordable Care Act in that time period. It wasn't one or the other, it was the combination of both of them. And I would argue it's the same thing on the policy front. So we have been talking a lot about single payer, we've been talking about for Medicare for all. In my belief, there is a very important role that those conversations have for someone like me who's trying to drive the system towards change. I think that there's a lot of pros to them. I think there's some cons. We've heard about that all today. But I would also argue that having some of the more moderated proposals are also important. And so for that reason, I want to spend the next part of this really talking about what it is that we in Massachusetts are doing and where we see the gaps in terms of getting us to universal coverage that's meaningful for all the consumers here in Massachusetts. We are very close in our numbers, but is the coverage as broad as it should be, and is it going to get the type of coverage for everybody that they really need and want? And so at Healthcare for All, we've been talking a lot about this concept around health justice, because we believe that that speaks not just to coverage, but it speaks to reducing inequities in our system and making sure that no one's left behind. And these are kind of the 5 points that I would argue would get us to a place where health justice is truly realized here in our state. So are we covering everyone? In particular, we're thinking about immigrants. Do we have affordable options for consumers? Right now we're hearing a lot about prescription drug costs, and so we're thinking a lot about that in this bucket. Are we thinking broadly about good health and thinking about the social determinants of health? Are we thinking about oral health care, and are we thinking about behavioral health services? And so I would argue that this is the frame which we're coming at the work here in Massachusetts to try to get us over that finish line and really having universal coverage that is helpful and meaningful for people. So I want to take each of these one at a time. So coverage for everyone. Obviously, there are a number of people that are still not covered, but at this moment in time, there's a significant attack right now on the immigrant population, and here in Massachusetts, covering immigrants has been an important part of how we see our state and the values that we have. So there's something called public charge. I don't know how many, actually show of hands, how many people have heard this term in the past? Okay, so this slide is actually already outdated, I apologize, but there is a term that's been used in immigration for many years now, which asks, is the person likely to become dependent on government for financial or material support? And they call this assessing whether somebody is a public charge. And the definition of what public charge has been pretty consistent for a number of years. They took into account things like cash benefits, things like Social Security, TANF, long-term care insurance, long-term care institutional payments. And these were the things that if an individual who was a legal immigrant and on the path to citizenship, these were things that could potentially impact their path to citizenship. But on September 22nd, which for those of you who were not, that is a Saturday night, the Trump administration released a new definition around public charge and a 400 and some odd page set of regulations that we had been anticipating for some time. And what this new definition of public charge does is a couple of things. So number one, it expands the number of programs that can kind of ding a legal immigrant on their path to full citizenship. So if you take Mass Health, if you take subsidies through Medicare Part D for prescription drugs, if you take SNAP, food stamps, if you use a Section 8 housing voucher or live in public housing, all of these will now be counted into the determination as to whether or not you are a public charge and whether or not you should be able to continue on your path to legal citizenship. And what's particularly scary about this is that it's not just what's happening at this moment in time. It's whether or not you likely in the future will use any of these services as well. And so it leaves an incredible amount of discretion to the individual who's making determinations about somebody's application for citizenship as to whether they think that they will be at some point using any of these services. What it also does is it basically says that if you are over 250% of the federal poverty level, which is about $62,000 for a family of 4, then you're kind of safe. If you are under 125% of the federal poverty level, it is a very significant strike against your application. And lastly, it also says, actually it says much more than this, but what I'm going to tell you right now, it also says that if you are sick or disabled and come into this country and do not have private health insurance, it is a very significant strike against your application. We're not talking about people who are here illegally. We are talking about people who have gone through the process of being here in the manner in which they're expected to. So this is a very significant issue that's consuming a lot of our time. We're working very closely with the administration to make sure that we're all providing counsel as much as we can to individuals. So when we talk about coverage for everyone, this is one of the things that we're really thinking about. In terms of affordability, the thing we hear about the most, well, not the most, but one of the things we hear about the most on our helpline is about the cost for prescription drugs. There have been a number of changes here in Massachusetts around our Mass Health program that have actually increased the number of payments people need to make for buying prescription drugs. And it's really something that is draining on individuals in a way that we've been hearing for a long time, but it's something there's definitely an uptick in what we're hearing. It's also worth saying that while consumers feel the individual pain, if the system is feeling pain, that also has an impact on consumers and what they're experiencing. So as we know, Massachusetts has the second highest healthcare spending level in the country, and in large part this is because of our spending on prescription drugs. We've done a much better job recently in moderating our growth. It's just up 1.6% last year, which is a big improvement. But we do know that both in the private and public programs, the prescription drug prices are continuing to increase. So in Mass Health over the past 5 years, we've seen a doubling of the cost of prescription drugs, so it's up to $2.2 billion. And in our commercial plans between 2015 and 2016, there was an average increase of prescription drug costs by 6.65%. So these are not small numbers, and these are having a tremendous impact. So the question is, what can a group like ours and the people we work with do around this? There's a couple of things. We have some existing laws on the book that we are interested in really making sure that they're better enforced and enhanced. Things like limiting marketing, thinking about drug coupons where physicians are giving coupons for expensive new brand name drugs to give out to patients, which is really helpful to them in the short term, but in the long term then they're using these more expensive drugs as opposed to maybe ones that have been on the market longer that could be working just as well for them. There's something called academic detailing, so many of you have probably experienced drug reps coming into your offices and talking to you about their new drug and why it's so important. We are trying to actually take those individual drug reps out of the process and have trained nurses and educators to come in and talk to you. You're interested in asthma? Let us tell you about all of the new drugs that are on the market so that you can make an informed and educated choice. We're also thinking very closely about what we can do around Mass Health. The governor had a proposal last year in the waiver application to the federal government that would have closed the prescription drug formulary for Medicaid. We would have been the first state in the country to do that. It certainly would have helped the governor and his staff have greater negotiating ability with pharma. It would have had some significant impact on consumers. And so that is now a proposal that's off the table, except the question is, what do we do now to think about reining in those prices in Mass Health? And lastly, I'm not going to go through all of these due to time, but there's a lot of new options that we're thinking about around review boards and transparency around drug companies' prices and profits, things that we have seen in other states, and we're going to start to explore those here in Massachusetts. Okay, so number three is thinking broadly about health. And this is a term that people are using more and more within the healthcare space, which is about thinking about the social determinants of health. Not just are we getting the health care that we need for the patients that you all take care of, but are we making sure that they're healthy and they're going into an environment that actually helps improve their health overall. So the accountable care organizations that Mass Health launched here over the past year, there's 17 of them. We moved 800,000 Mass Health patients into these ACOs over the past 6 months. There's a requirement that these ACOs screen for issues around social determinants of health, specifically housing insecurity, food insecurity, transportation needs, and exposure to violence. And there's an expectation then that practitioners will refer people to community-based organizations to try to help them address these needs. Obviously, this is extremely complicated. We have lots of questions about whether the community-based organizations have the ability to absorb the influx of these referrals. There's a lot of work going on that's both exciting and also needs a lot of attention. Our organization is working very closely with MassHealth and a lot of researchers and individuals outside of our organization to figure out how we can really use this opportunity to be a leader nationally around thinking around social determinants. Number 4, oral health. I mean, we kind of joke that like people sometimes forget that the head is part of the body, and when we think about healthcare for people, we sometimes forget about the mouth, and that is clearly it's a huge issue. I think we got 400 calls last year on our helpline specifically about oral health concerns. And so thinking about oral health integration is a real unique opportunity that we have right now. We have health centers here in Massachusetts and other facilities that have fully integrated oral health care into their clinics and into their facilities. So there's literally dentists and doctors practicing in the same place and able to refer each other. And that's kind of the vision that we have. And we're working very closely with Secretary Sebelius and her staff to try to think about how, as we move into these mass health ACOs, the next phase is how can we integrate oral health further into it. It's also worth noting that we have a very significant shortage of oral health providers here in Massachusetts as well. About over 500,000 people in Massachusetts live in what's called a federally designated dental care health shortage area. Heard an interesting statistic the other day that out in Berkshire County, over 60% of the dentists are at retirement age or older. Clearly that's going to present a problem. And one of the things that we've been working on, and I know I might get a little, is a scope of practice bill. But it's a bill that would create a new member to the oral health team called dental therapists. And they'd operate somewhat like a nurse practitioner in the oral health community. Ideally, they would be able to operate under general supervision from a dentist, meaning they could be under the supervision of a dentist, but they could be at Head Starts and at senior centers and at schools providing routine oral health care, particularly for mass health patients, but also about 50% of their patients would be from other payers. This is a highly controversial issue. We came really close to crossing over the finish line this year. We had the dentists and the advocacy community at the table with a deal. It got hung up in the omnibus healthcare bill that failed in the 11th hour of the legislative session, but we're working on going back in partnership with the Dental Society to try to get this over in the next year. And lastly, but certainly not least, when we thinking about the head, we also have to think about behavioral health care. We have parity laws on the books, but whether that's actually the case in practice, it's not always how it plays out. We have gaps in coverage. We have significant shortages of beds that are able to treat all sorts of behavioral health issues, particularly substance use disorders. We have a particular shortage around children's health care access. We have a number of children who, as you probably all know, will live in the emergency department for weeks at a time waiting for placement in a facility. We are very proud to be part of what's called the Children's Mental Health Campaign. We're doing a lot of work around integrating behavioral health, and I think I'm short on time, but there are a lot of different projects from maternal and child health to screenings and other things that we're doing. One of the pieces that we're particularly focused on is actually on provider directories. Even though there's a shortage, it's hard for people to actually find providers that are taking new patients, and the provider directories are woefully out of date. We were very proud of the ability to broker a deal with providers. We worked really closely with the Medical Society here, with insurers, and with others to come up with a new path forward as to how we can keep these more updated and current, so that patients who are calling our helpline who are panicked because their child needs to see a mental health practitioner and they can't find anyone that's accepting patients, and things are woefully out of date. So I will stop there. For all of you here who are interested in advocacy, come join us. check out Healthcare for All and feel free to sign up to receive our updates. We take great pride in working with many physicians across the Commonwealth and would welcome your partnership. Thank you.